bang. I guess that would be or a crack. Not so much a bang, but a crack. That's a good point. And so we're talking about ED thoracotomy. We're going to talk about some of the situations in which you want to do it, and like everything in trauma, and sort of this is the basis of our trauma lecture series, is that there's actually very little evidence for like some of the big stuff, right? Like it's really hard to randomize that I'm going to crack your chest open, but I'm not going to crack your chest open, right? Like it's really hard to do a lot of those studies, so a lot of the trauma guidelines are based on consensus, right? So there's lots of room for debate in them, and there's lots of room for understanding why we do some of the things that we do. So this is one of those things. So we'd start with this one. So with that, I give you Kylie.
So my name is Kylie Birnbaum. I'm a third-year resident. I'm going to be talking about ED thoracotomy. I want to thank Dr. Jane, Dr. Hernandez, and Dr. Sassi. You're the heart to my clamshell. My objectives today are going to be just to talk about a little bit thoracic trauma and what is an ED thoracotomy, and quickly on here run through the steps of how to do it. But after that, we're going to do more of a demonstration, so it'll just be a little bit of a run through. And then I'm going to talk about what we can really achieve with an ED thoracotomy and the indications for this. And then there's a lot of controversy and kind of different guidelines. The Eastern Society, the Western Society, they have different guidelines, so we'll go through those and why they have those certain guidelines. And then Dr. Jane's going to talk a little bit more about contraindications in particular. So thoracic trauma is important. 25% of all trauma deaths are from penetrating thoracic trauma, and traumatic arrest is important to know how to deal with. Our typical closed chest CPR and ACLS is not going to work. These patients go into traumatic arrest usually from severe hypovolemic shock and hemorrhage, or from severe tamponade, and pushing on a closed chest is not going to achieve what we need, nor is epinephrine or the other ACLS meds. So what we really need is blood, hemorrhage control, opening the chest to do open cardiac CPR, and evacuation of tamponade. So quickly, resuscitative thoracotomy or ED thoracotomy can be a life-saving procedure in the right patients. It allows exposure of the heart, the lungs, and the vasculature, and it really is just a temporizing measure. You have to have surgeons to back you up, and definitive treatment is going to be to go to an OR after that. So either they'll be pronounced dead after you attempt the thoracotomy, or they'll go to the OR if you can save them. So what we can fix with an ED thoracotomy, our best bets are to relieve tamponade, control hemorrhage, and do open cardiac massage. And then we're going to run through some of the steps, but theoretically we can also treat air emboli, cross-clamp the descending aorta, and repair any cardiac injury or pulmonary injury. This doesn't have as good of outcomes as the top three, though. So quickly, the major steps, and like I said, we're going to run through this on a real model, but it's going to be, you're going to intubate the patient, obviously. You want to right main stem them. It's kind of one of the only times that you want to selectively right main stem them. It's going to deflate the left lung, get that out of the way for you to have better access on the left side. Patient's going to be supine, left arm above the head, and you're going to make an incision on in the left fifth intercostal space. It's going to be curvilinear following the rib line, kind of up into the armpit. That's going to get through the skin and soft tissue. From there you could either use scissors or blunt dissection to get through the muscle layer and the pleura. You're going to put your rib spreaders in, crank it open, crack the chest. From there you're going to push the hopefully deflated left lung out of the way, find the heart. You're going to identify the phrenic nerve, and do not touch this. You're going to want to go anterior to make your incision on the pericardium to the phrenic nerve. From there, hopefully you'll relieve the tamponade. You could do an open cardiac massage once you deliver the heart. You could plug any holes that are there. And if that doesn't help, then you can start looking around for other things, other signs of hemorrhage, or cross-clamping the descending aorta. Other things. Oh, and then this is a quick video in a very controlled manner.
Resuscitative thoracotomy. The patient is placed in a supine position with the arm extended above the head. The patient is deliberately intubated in the right brainstem in order to collapse the left lung. The incision is made along the fifth rib from the sternum and extended to the posterior clavicular line. Blunt-tip scissors are used to cut into the intercostal muscle just over the fifth rib.
That incision is really short. You should really go down to the bed.
Should go all the way from the sternum all the way down to the back.
Yeah.
The rib spreader is placed, and the ribs are separated.
Down. Yeah.
Crank it bottom.
Crank at the bottom? Yeah.
Yeah, so that you want the bar to
The
be
left upper
along the
lobe of the
bed.
lung is moved
Let's
in order to
move to open
expose
up.
the pericardium. The phrenic nerve is identified. A gentle incision is made above the phrenic nerve in order to expose the heart. The rest of the pericardium can be spread manually.
Usually just go with their scissors up and down.
This maneuver
It's
will
faster.
decompress the pericardial tamponade
Yeah, make
and
sure you cut the
provides
same direction
access
as
to
the
the
front
heart
nerve. Don't cut
for
across.
repair and cardiac massage.
Is it worth it to try to like isolate the front nerve in any place with any?
No.
Just don't cut it.
Just don't touch it. Know where it is that you know to avoid it.
When you said spread, would be better to flip the rib spreader so that the bar is on top?
No.
It's easier for you to crank, but then if you have to convert it to a clamshell, you can't go across with the metals in the way.
So you always put the bar at the bottom, you can go
The bar is always the bottom.
Floor.
Always the bottom. So when you go to cut across, you won't be able to do it with the rib spreader.
If you have the clamshell.
Your brain's gonna want you to put it up top because it's easier.
Okay.
Because it's usually do that with the bottom.
That's not correct.
We're gonna go through some of that when we actually.
It's because you didn't close the.
No, it's right.
This is 7 8
All right. Continue on.
Okay, so now that we're kind of all on the same page about what a thoracotomy is, what we can fix with it, I'm going to specifically talk about the indications to do a thoracotomy. And these are just a list of the things that we look at that can kind of help determine which patients are indicated or not. So the location of the injury, mechanism of injury, whether there's any signs of life in the patient, which we'll talk about, and the physiologic status. And then what you want to get from EMS is how long CPR has been going on. You're going to use bedside ultrasound, which I'm going to talk about at the end, specifically looking at cardiac motion and any tamponade. So for mechanism, it's going to be either penetrating trauma to the thoracic region, blunt injury to the thoracic region, or some sort of penetrating trauma not to the thoracic region. And we'll go through that. Stab wounds and gunshot wounds are going to be your most common injuries, penetrating injuries to the thoracic region. Stab wounds do tend to have the best outcomes. It kind of makes sense. They're more direct, they tend to be smaller, and if they do violate the myocardium, they tend to tamponade off because they're a little bit smaller. Versus gunshot wounds, as we all know, the trajectories can be very unpredictable. They could hit a wide variety of structures, and if they violate the myocardium, they tend to be bigger and hemorrhage out versus tamponade. Blunt injuries have kind of universally the worst outcomes, and this kind of makes sense. These are patients who are going to be either victims of horrible car crashes or some sort of blunt assault or crush injuries, and a lot of structures are going to be injured. Even if you do your ED thoracotomy and you kind of control hemorrhage, oftentimes there's going to be myocardial contusions, which is going to affect how the heart functions in general. So the interventions that we can do, the heart, is still going to have some sort of failure, like intrinsic failure from damage. And then non-thoracic, penetrating trauma. These are indicated for neck trauma, abdominal trauma, and penetrating extremity trauma, where the patient is absolutely exsanguinating and you can't get control otherwise, and they go into a traumatic arrest. And what's important here is cross-clamping the aorta and doing open cardiac massage. So our first study of guidelines put out by the American College of Surgeons just looked at what we talked about, the mechanism and locations of injury for their guidelines. This was done in 2001. They did a rigorous literature search. Like Dr. Jane mentioned, not a lot of class 1 evidence, no class 1 evidence, because there's no real randomized control trials. But they did a literature search and included 29 studies with class 2 evidence, 36 with class 3, 63 with class 3, for a total of 7,035 ED thoracotomies. They had a total survival rate of 7.8%. And as we can see, penetrating trauma, 11% survival rate versus blunt trauma, 1.6% survival rate. And then in particular, penetrating cardiac trauma has the best outcomes here, 31%. So their guidelines based on mechanisms was that blunt trauma is rarely an indication for ED thoracotomies, only if they have vital signs and lose them right in front of you. They cardiac arrest in front of your own eyes. Otherwise, they say no. However, for penetrating cardiac injury, because they're much more likely to survive, they do recommend it in most cases, especially with short transport time and some sort of witnessed or objective signs of life, whether in the ED or at the scene. And then they just kind of say judicious selection for exsanguinating abdominal injuries. So what are signs of life? This means any cardiac activity, including pulseless electrical activity, any sort of organized rhythm on the monitor, brainstem reflexes, so your pupillary reflex, gag reflex, spontaneous breathing, corneal reflex, any spontaneous extremity movement, any sort of palpable or measurable blood pressure, carotid pulse, and a GCS that's greater than dead, basically. And then some studies look at physiologic status, and this just means patients categorize either physiologic status of 1, that means they have no signs of life. And in general, those patients are not usually indicated for a thoracotomy, but as we'll see, newer guidelines do include them. But our class 2 and class 3 physiologic status is going to be more useful for an ED thoracotomy. Either they're in pulseless electrical activity or they have such profound shock that's not responsive to fluids that ideally in this case you'd want to get them to an OR immediately, but if for some reason you're a little bit backed up, it can be an indication to do this in the ED. And then patients in class 4 are not sick enough to require that. So how do we put this all together? We have all these different categories that can be indications, but evidence is really lacking. So what the two kind of societies, the East and the West, tried to do was combine the categories to make a realistic picture that we could use, realistic rhythm, algorithm. So I'm going to start with the West because this came out first. That's Tupac. So this was done in 2012. They had kind of two papers that they published. One was a large review of literature that put out their guidelines. And the other was of the Western Society of Trauma. There's 18 hospitals in that association, and they used prospective data over 6 years of their ED thoracotomies. They found that injury and transport time were two good indications to be put together, so their guidelines are going to be based off of that. And then importantly, they say that any patient with signs of life should have an ED thoracotomy. They call this a state of profound shock that could have a benefit from a thoracotomy. So they found that a penetrating trauma, this is in their literature review, penetrating trauma and profound shock has a 35% survival with ED thoracotomy, versus all penetrating trauma, 10%, blunt trauma with signs of life, a 2% survival, and then blunt trauma without signs of life, less than 1%. And then, like I said, there were 18 hospitals that they did their own prospective studies on, and they used 56 survivors' data from there. So their guidelines are just based on who survived in those 56 patients mostly. They found that, and these are all going to be patients without signs of life, because any signs of life is considered profound shock, and you should do an ED thoracotomy, they say. So without signs of shock, penetrating thoracic trauma with CPR going on for less than 15 minutes, they recommend. Any blunt thoracic trauma with CPR for less than 10 minutes, they recommend. And then any penetrating neck or extremity trauma with CPR for less than 5 minutes, they recommend. Yes?
Maybe Dr. Jane can comment, but is there any indication to do CPR in a person with penetrating trauma or blunt trauma?
There is no good evidence for either, because if you're doing CPR against a hole somewhere, you're just pumping more blood against that hole.
Yeah, you also need a full heart to pump blood anyway, so if they're dead because there's no blood in their heart, you have nothing to pump. So CPR is a waste of time. You shouldn't be doing that on trauma patients.
Correct. I mean, most of our EMS guys do it because they're just taught to do CPR.
Yeah. This is not going to be, as soon as these patients roll in, you have to make the decision right away to do the ED thoracotomy. You're not going to sit there continuing CPR. I think this was just mostly used as like a measure for how long they've been down. CPR is kind of the transfer time and how long they've been down. And then they also found that there were actually 7 survivors, which I'm going to talk about, patients that had complete asystole when they came in, but were found to have pericardial tamponade that survived after an ED thoracotomy. This is the algorithm that they came up with. Obviously, you don't have to know all this, but I just kind of want to point out up here. So patient undergoing CPR with no signs of life, if they meet these time requirements, then yes, do a resuscitative thoracotomy. If not, call them dead. If they have signs of life, then they're considered in profound refractory shock, and it doesn't really matter if CPR has been going on, you should do the resuscitative thoracotomy. And then all of this over here is kind of once you open the chest, the route they want you to take, which I'm not going to get into right now. All right, so then the Eastern Society of Trauma Surgeons, which is their own group, in 2015 came up with their own guidelines, and what they did was a very large retrospective kind of meta-analysis, 72 studies, over 10,000 patients with ED thoracotomies, and they identified 6 categories with 3 different survival predictors based on mechanism, location of injury, and whether or not there were signs of life. And then this is kind of interesting. So they have the data that I'll show you that gets into the survival based on ED thoracotomy, but then they had all these expert committees kind of decide if this same patient came in and did not have the ED thoracotomy, based on my expert opinion, what would have been their chance of survival, and that's how they kind of compare whether or not they recommend thoracotomies. And I like them because they do factor in whether the patient is neurologically intact as a factor for their guidelines. So this is just their kind of table 1, all of their patients in the study, and what I just want to point out is that we see penetrating trauma has a total survival rate of 10.6%. Better with stab wounds, not quite as good with gunshot wounds, but 90% of patients with penetrating trauma that survived were neurologically intact. And that's huge. That's a really good sign. Versus blunt trauma, where only 2.3% of these patients survived, just a little more than half of them, 59%, were neurologically intact. So that's going to be a big kind of indication and factor to think about. Right? If you're saving these patients but they're not neurologically intact, what are you really accomplishing? So these are their categories based on penetrating blunt or penetrating non-thoracic trauma and whether or not they had signs of life. All the patients are pulseless, and by signs of life, they really mean signs of life in the ED at presentation. So next few slides, there's a lot of numbers. I'm going to just go through it quickly. The best category that they found is obviously penetrating trauma, thoracic trauma with signs of life. They had a survival rate of 21%, and 90% of these are neurologically intact. So the committee very strongly recommends doing ED thoracotomies in these patients. If they came in with penetrating thoracic trauma without signs of life, their survival rate was less, but at 8.3%, but still not horrible. So they do conditionally recommend it. And then extra-thoracic trauma with signs of life, they had a good survival rate, 15%. Without signs of life, not as good, 2.9%. But they estimate that if the ED thoracotomies weren't done in these patients, they'd have a 0.1% chance of survival. So based on kind of the relative increase of life here, they do recommend it for both of these categories. And then lastly, for blunt thoracic trauma, patients who came in with signs of life had a 4.6% survival rate, but remember, only 59% of these are actually going to be neurologically intact. So it's really more like a 2.4% survival rate in terms of functionality. But still, given that, the committee does recommend it. And then our last category, blunt injury with no signs of life, they had dismal survival rates. Even with ED thoracotomies, 0.7%. Only 59% of those are going to be neurologically intact. So for this, the committee does not recommend it.
So it seems to me that with the extra-thoracic trauma, the cross-clamping of the aorta is the main thing that's going to save these people. They differentiate between that, like not cross-clamping and cross-clamping, or?
They did not, but
Is that just assumed?
But I'd assume that that's going to be your main intervention, doing a thoracotomy in those patients. Yeah. So just to kind of visualize it, penetrating thoracic trauma with signs of life, very, very strongly recommend thoracotomy. Blunt thoracic trauma with no signs of life, do not recommend it. And everyone else, not quite as good of survival, but enough for them to conditionally recommend it. And this whole conditional, like soft recommendations are because it was a giant panel of surgeons and they had their own internal disagreements. So that's why it's, except for everyone agreed on that one category, signs of life and penetrating trauma. So no one's really talked about ultrasound yet as a tool, but in 2015, a good study came out of USC looking at a cardiac fast. Could this be used as a guideline for possible survival? They looked at cardiac motion and pericardial fluid, and it was done only at USC over 4 years. It was a prospective study. They had a total of 224 ED thoracotomies. 187 of them had the fast done, so they were included in the study. 3.2% of all their patients survived, which is lower, I think, than we've seen in the other studies for total survival. And I think that's because what I've heard from people who work there is they have a pretty liberal use of thoracotomy, and they have a lot of blunt trauma with their
4 years at
freeways and stuff.
224.
Yeah, pretty liberal. This is like one of the only times I saw it was when I rotated at LA County as a med student. So in their study, this was pretty remarkable, I think. They found, so about 29% of all patients had cardiac motion on their ultrasound, but 100% of their 9 survivors had cardiac motion. So that's 100% sensitive to predict potential survival. And then conversely, without cardiac activity, that's a negative predictive value of 100%. So it's pretty good. They didn't find any association with pericardial fluid, which is interesting, but another study did, which I mentioned before, that there were 7 survivors in this group that had asystole with pericardial fluid or tamponade, and they all survived. So I think we can put these 2 ultrasound studies together and find that ultrasound can be very helpful. In particular, if they have asystole with pericardial tamponade, that could be an indication. And then if there's any sort of cardiac motion, that could be a potential predictor for survival. And I like it because it's something that the whole room can see, right? You could put the probe on someone and either you see tamponade or you see cardiac motion, and everyone can get on board that this patient may have a shot at survival with an ED thoracotomy, versus you put the probe on and you don't see any of that. I think everyone in the room can also be on the same page with calling it there.
Question, Dr. Jane.
Yeah.
If you see tamponade in arrested patient, traumatic patient, would you go to do precardiocentesis, or you just go directly to a VG thoracotomy?
After chest open. There are no pulses? Why?
No pulses, tamponade, blunt trauma. You don't
Open them up.
aspirate,
Takes you longer, right? You have to deal with what caused the hole.
just open the chest.
Open the chest. Open them all.
No precardiocentesis.
So just the takeaways I want you to get from here, that thoracotomies can save lives. I think I was pretty impressed with the numbers of survival rates here. How many of you guys have been part of a thoracotomy, seen one, done one? Okay, and of those raising your hand, keep it up if your patient survived.
Survived in the OR.
No, out of the hospital, left the hospital.
I've seen elevators.
Like one that walked out, but he was stabbed left side in the chest.
Right there, so that's your best bet. But I was still kind of, I thought it was pretty interesting how good the survival rates are in these studies. Yeah. So my takeaway is basically penetrating trauma, signs of life, short CPR time. These are all very favorable indications that you should strongly consider doing thoracotomy. And Dr. Jane's going to talk more about not doing a thoracotomy.
So I think that your patient is the exact right patient to have done this for, right? So single stab to the chest is the person that's going to,
Perfect.
so it's a perfect segue into the next part, right? Because at the end of the day, you want to be somewhat selective in who you crack the chest on. And that's why in the LA County and USC study, they had such a low survival rate because they were cracking everyone's chest, right? 224 chests in 4 years. That's like one every other day practically, right? So that's, granted, they also have a lot more violence there, but at the same time, that's also being very liberal with your indications. So that's sort of the key here is to be slightly more selective about whose chest you crack because there are consequences. So I'm not going to bore you with the history. I put it in thinking that we were going to have more time, but I know everyone is really more excited about the stuff on the table instead. So the funny part about all of this is when it was originally described, it was only described for chest trauma, right? So sort of going back to the original indications for cracking someone's chest, those are the reasons to do this, right? So when do you cut, when do you not cut, is sort of the big question. So one, you have to know how to do the procedure, right? We're going to go through it, but understanding your own limitations. If we do it today and then your next patient isn't until next May, then perhaps that's something to think about as well, right? Can I actually do this procedure? Do I actually know how to do it? And that's something to consider. What is the likelihood of survival, right? So again, being slightly more cautious about who you choose to do this in. And then important is to know where you are, right? If you're in a community hospital where you don't have trauma surgeons, you may not even have surgeons on in the hospital at night, and if you certainly don't have either trauma surgeons or CT surgeons to take this patient to the operating room after you've cracked their chest open, that's not the person you cracked their chest on, right? So sort of understand where you are and what are the implications of your actions. Because if you have no one to take them afterwards, then great, so now you have a guy who has the chest open, and now what do you do with them, right? So understand that sort of limitation, and then also recognizing that while this is somewhat questionable for the patient, it's also very questionable for all the staff in the room. There's a very high incidence of needle sticks, scalpel injuries, blood getting splashed into people's face, all these sort of risk factors to us as the providers when doing these procedures. The other one that we tend not to think about is one, especially if you have multiple injuries to the chest, there might be broken ribs. So in that video, you guys saw how when he was cutting through the muscle, he started using his fingers to cut through the muscle. That is not what you want to do. That's how people end up with rib fragments in their own hand, right? And also when you're cracking the chest, you will sometimes, if you're over-aggressive with the crank, you will again break ribs and injure yourself on those broken ribs. So there are risk factors to us, right? So like Kylie was saying, know your injury, right? Who is the right patient to do this on? And again, there are there's so much evidence that the patients who do benefit are the ones who have penetrating injury to their chest, right? So all of the other ones, they might survive, right? 2%, 1%, something of those percents, but the best patient to be selective about is the person who has the injury that's to their chest wall. Someone, when you crack their chest open, you can actually find the hole, stick your finger in a hole, and fix it. Right? I mean, you're not going to be the one to fix it, but you're going to be the one to temporize it. Or maybe they have a stab wound or something is ripped, right? So you can actually find their injury by doing this horrific, very, someone was describing, it's a very like barbaric, thank you, that's the word I'm looking for. It's very barbaric to sort of crack someone's chest open. And then when you clamshell them, it's even more barbaric because now their whole chest wall is up on their face. So now in this particular study, so this is again part of the Western trauma stuff, they were really good about isolating, when you go through, they're isolating for what type of injuries, 15% for all, but the ones that did the best were the ones who had penetrating chest. Here's another one. This is from Reed from from chest. This was looking at whether they had signs of life. If they did not, the location of injury, their mechanism of injury, and then same thing. Stab wounds to the chest had the best outcome. Gunshot was second, not as best, not as great outcome, but still had a better survival rate than if you had gunshot to anywhere else. Because like you're saying, the assumption is you're cross-clamping, right? That's why you're trying to get to the chest wall. But oftentimes we're not cross-clamping correctly either, and we're going to go through that really quick. So using ultrasound is a really nice tool. So as soon as a patient comes in with traumatic arrest, while someone is getting ABCs, I'm sure if you've been in the room with me, the first thing I do is I have the probe in my hand, right? Because if I don't see anything that I think I can fix, that we can fix by cracking a chest open, then what is the utility in subjecting everyone in the room to it, right? So if you have something, these are supposed to be videos that we're supposed to play, but if you have an ultrasound like this, right, there's a huge pericardial effusion. It's kind of obvious, right? This is the person whose chest you want to crack, right? Because you're going to relieve the tamponade and you might actually get them back. Oh, thanks. Right, so they've got tamponade, there's the waterbed sign right at the top. You know that this is clearly why they don't have vital signs. Versus this one, even better, right? There's no cardiac movement. This person is not moving because of that tamponade. This is the person, I would say, who has the knife in their hand already, right? And if you don't, then I'm doing it. However, this might not be your ideal person, right? Someone who has no signs of life, or someone who has no pulses, is not really responsive, no neurological status. There's been some amount of downtime. And now there's no pericardial effusion. Don't mind the fact that the heart's actually beating really well. Just pretend it wasn't so full. Rarely do we ever save images of people who don't have moving or have very full hearts. So exclude the idea of a very well beating heart. Right. The idea is that the pericardium is nicely intact. So the next one is timing, right? So how long were they down for? How many of you guys have had a patient who was a traumatic arrest and EMS says they just lost pulses at the door? Right, all the time. Or they were in the ambulance and then as soon as we got them in the ambulance, then they lost pulses, right? So that happens all the time, right? So timing is everything.